Making the Rounds lecture series, and today's topic is otolaryngology care during a pandemic with Banner University Medicine's Department of Otolaryngology, Dr. Eugene Chang, Dr. Helen Yip, and Dr. Stephen Wang.
Okay, so I'm Dr. Steve Wang. I'm the chair of the Department of Otolaryngology, Head and Neck Surgery here at the University of Arizona College of Medicine in Tucson. And you've heard from Dr. Yip already about some of the interesting COVID-related ENT cases that we've been seeing over the past year. In the next part, I'm going to share with you some of the other many unique services that we and our ENT team provide, and tell you in the context of a bit of story of the COVID pandemic and how we as a otolaryngology specialty had to learn pretty early on how to safely provide ENT care to our patients, and some of the lessons that we've learned from that. So let me first take you back to when we started receiving some rather disturbing reports of how otolaryngologists were among healthcare workers that were at the highest risk for COVID infection. In January of 2020, there was a report of a combined ENT neurosurgery OR case of a patient in Wuhan, mild flu-like symptoms, and there were at least 14 OR personnel who became infected with COVID after that case. In March, there was news of 2 otolaryngologists who were the first healthcare worker COVID-related deaths in the United Kingdom. So why is the ENT practice at a higher risk for COVID infection? Well, it makes sense in that we know that the coronavirus concentration is highest in the nasal cavity, nasopharynx, and throughout the epithelium of the upper aerodigestive tract in COVID-infected patients, some of whom are not even symptomatic yet. While ENT surgeons commonly perform procedures on the upper aerodigestive tract, both diagnostic and therapeutic, where manipulation of that upper aerodigestive tract epithelium may very well cause high levels of aerosolization of coronavirus. In addition, many of the common ENT surgical procedures that we do in the OR are also highly aerosolizing, and some of them, particularly head and neck cancer surgery cases, may go on for many hours and therefore put multiple OR staff at risk for aerosolized transmission of COVID. So on March 19th of last year, our American Academy of Otolaryngology sent an urgent message to all of its members, stating that there is evolving evidence that otolaryngologists are among the highest risk group when performing upper airway surgeries and examinations. A high rate of transmission of COVID-19 to otolaryngologists has been reported from China, Italy, and Iran, many resulting in death. So I can certainly tell you that this really sent a shockwave through otolaryngologists throughout the United States. The Academy of Otolaryngology recommended that we immediately cancel all elective airway procedures in the clinic. For urgent upper airway procedures, they recommended maximal PPE precautions, either N95 or PAPRs. And this, as you recall, was a time when such PPE was in rather short supply. They also, Dr. Yip alluded to, that elective tracheotomy in COVID patients should be approached with extreme caution. So if you recall, in Arizona, as well as in many parts around the country, back in March and April of last year, that much of the healthcare system severely curtailed their elective services in order to conserve precious hospital resources, PPE, ventilators, and such. But in the ENT world, we essentially went even further and basically shut down pretty much all elective in-office and inpatient procedures except for emergencies. So what did we do during that time? And I say this acknowledging that in other parts of our country, many of the ENT physicians, particularly in New York and the Northeast, worked as hospitalists and really just pitched in wherever they could. We didn't have such a surge in Arizona, and so during this time period, we spent a lot of time studying and learning and trying to figure out how we could resume doing our ENT practice and how we could safely do ENT, particularly aerosolizing procedures, both in the clinic and the OR, in order to keep our patients, ourselves, and our staff safe from COVID. So we learned a lot about things that I previously certainly did not know much about, including COVID testing, the different types of PPE, and in particular, many of the environmental safety issues, such as room ventilation, air filtration, the different types of negative pressure isolation rooms, really all an attempt to how we could prevent the unintended aerosolized airborne transmission of coronavirus. Looking back on that time, it's a bit ironic because now we know the WHO and CDC has confirmed that COVID-19 is actually mostly airborne spread. But what I think is important is that what we kind of had a one-year head start as otolaryngologists and learned a lot about how we could do our ENT practice safely, which I think can be applied today in many other both medical and non-medical settings. So some of the challenges that we faced as a specialty, particularly in our clinics, is that unlike many other medical clinics, we're really dependent on the need for patients to come in person. It's not really possible for us to shift to telemedicine for most of our patients, because many of our patients, I mean, the reason they come into clinic is for certain diagnostic or therapeutic procedures that we're going to do, and unfortunately, many of those are highly aerosolizing, including scopes that are placed in the nasal cavity, the nasopharynx, or to observe or perform procedures in the larynx. And even many of the routine oral nasal exams that we do may induce gagging, coughing, sneezing, or other aerosolizing activities. Well, we first focused on the inpatient in the OR, and because many of those procedures, even the urgent ones, we still needed to find a way to do, particularly our cancer patients. And so we were very early advocates for COVID testing, and as you recall, during the spring, this was difficult to get. It was also the turnaround times were very long, such that it really wasn't really useful in terms of being a reliable assessment of what a patient was by the time they actually had their procedure in the setting where there was widespread community spread. But as I mentioned, we felt that this was highly important, even though this was a precious resource, because of the fact that the aerosolizing nature of our procedures, many of them go on for many, many hours, potentially exposing multiple OR personnel, as well as the fact that post-operatively, the care of these patients might further expose additional healthcare workers to aerosolizing transmission, for example, patients with tracheotomies. So we really pushed for proactively for pre-op testing. And what's interesting is this really, in a sense, became a model for when the state of Arizona mandated pre-op testing for all surgical cases. We want to make sure that, in particular, the test accurately reflected the patient when they had the procedure. So in certain cases, we would do a second test that was done with rapid turnaround within 24 hours of the procedure. Regardless of the test result, for the higher risk aerosoling procedures, we utilized N95 masks for our surgeons as well as all the staff in the OR during these procedures. And in cases where there were emergencies and we could not get the pre-op testing in time, we performed these aerosolizing procedures in negative pressure isolation rooms. It was mentioned by Dr. Yeh specifically with regard to tracheotomies. As I mentioned, our own academy had cautioned, as these are really a last resort, but as these cases increased in our hospital, this became an important thing for us to be able to do. And so our service was very active in developing a banner-wide protocol. And in our hospital, we developed a specific protocol that emphasized safety. So we had a dedicated limited staff that performed these procedures. We did them in the ICU at the bedside to minimize transport of the patients. And as you can see in the photograph, we did them with pure airified respirators. Initially, our service performed all the COVID tracheotomies at our hospital. And then as time went on, we also included our pulmonary colleagues in these cases. With regard to the clinic, we did a number of measures to try to create a safe environment as we move towards reopening. We converted 3 of our exam rooms to negative pressure isolation. We installed portable air filters in many of our exam rooms. We extended patient scheduling and increased the time interval for room turnover after certain procedures from 1 to 3 hours. And then for certain interventional procedures, we were able to attend pre-procedure COVID testing. We kind of self-designed these what we call valve masks to allow us to perform nasal endoscopic procedures with minimizing our risk to transmission. And then we wore N95 masks and face shields when we performed these procedures. And then as you can see here, we made a video highlighting some of the safety precautions that we were taking. We released this to our patients. and welcome them back to clinic. And by the end of May, we were pretty much fully open. Last June was actually one of our busiest months. So the next part, let me just share with you some of the services that our ENT team here in Tucson is able to provide, and then talk about how those services were challenged in the past year by the COVID pandemic. This is our head and neck oncologic surgery team, and I'm proud to be part of this with my colleagues, Dr. Baker and Dr. Borelli. We work with our colleagues in medical oncology and radiation oncology through the UACC Cancer Center, which is the only Arizona-based NCI-designated comprehensive cancer center. And many of the surgical procedures that our ENT surgeons do at BMC Tucson are unique and offered nowhere else in Southern Arizona, including microvascular free flap reconstruction for head and neck cancer surgery, transoral robotic surgery, or TORS, which is a minimally invasive surgical approach for oropharyngeal and laryngeal tumors. Endoscopic anterior skull-based surgery is done in collaboration with our neurosurgery colleagues, and comprehensive surgery and reconstruction for many advanced skin cancers and melanoma. A couple of the interesting things that we initiated during the last year in the middle of a pandemic. Really excited to have delivery of the new Da Vinci SP robot, which was FDA approved for transoral robotic surgery last year. And we received delivery of our robot at the end of last year in December. It is the only Da Vinci SP robot in Southern Arizona and one of only 3 in the state, and allows us to very precisely perform transoral resections of tumors in the oropharynx and larynx. Dr. Borelli and Dr. Baker perform complex microvascular free flap reconstruction after major head and neck cancer surgery. This is an example of where we are able to use virtual surgical planning to optimize the reconstruction after head and neck cancer using a fibula free flap, where preoperatively, based on high definition CT scanning, patient-specific cutting guides for the mandible and the fibula are made. And then during the surgery, this preoperative custom-made plate is used to secure those fibula free flap reconstruction, allowing our surgeries to be performed more quickly and more accurately than in the past. Some of the challenges our head and neck cancer patients face during the pandemic, as is well known throughout cancer care, the quarantine shutdown caused many people to delay seeking care and present at a more advanced stage, which is obviously not good. Many of our head and neck cancer patients have different options for their treatment, both surgical and non-surgical. And so the COVID risk became another factor that had to be assessed in deciding their care. And we often had to balance the COVID risk of a prolonged, highly aerosolized surgical procedure versus the COVID risk of the immunosuppression associated with chemoradiation therapy, as well as the fact that those non-surgical regimens actually involve more in-person interactions over many weeks. The shutdown disruptions also really wreaked havoc on our portfolio of clinical trials for our patients, and so our enrollment and participation of patients suffered. A major problem also with head and neck surgeries to note is that many of these cases require prolonged inpatient admission in ICU post-op care. And as you know, through much of July, as well as from mid-December through all of January, our hospitals and particularly our ICUs were completely full. And so that really required us to come up with creative solutions. Patients that would typically have long ICU stays, or at least several days of ICU stays, in some cases we had to admit those patients directly to the floor or accept very short ICU stays, sometimes just overnight, for many of our complex trach and free flap reconstructive surgery patients. Moving on to our pediatric otolaryngology division, led by Dr. John Skirko, who is the director. He carries out many both straightforward ENT procedures like tubes and tonsils and congenital neck masses to some of the more complex craniofacial anomalies and reconstructive surgery. In regard to pediatric ENT care during the pandemic, we saw a significant decrease in volume of these patients, and it's interesting to ask why that might be. Possibly parents were afraid to bring their kids to medical attention. We did know that many of the pediatricians had switched to telehealth, and so we wondered perhaps whether there were less referrals because those exams were not being done as much. Or it also could be that there were simply fewer pediatric ear infections, flus, colds, other infectious conditions that typically prompt patients to seek medical attention that were just less because of social distancing because the schools weren't open. And so we wonder if we may see actually a very big rebound in the volume, but we may see, similar to what we saw in our head and neck cancer cases, perhaps more advanced disease in the coming months, and that's something we'll have to be on the lookout for. With regard to rhinology and skull-based surgery, you briefly met Dr. Chang, and he works closely with his partner, Dr. Chris Lay. They offer endoscopic sinus surgery for a variety of inflammatory conditions. We also have allergy and immunotherapy treatment offered. I already mentioned the complex anterior skull-based tumor surgeries that our rhinologists do with our neurosurgeons. And we really become a destination site for the management of invasive fungal sinusitis for patients across the state. So some of the challenges that were faced here is that many of these cases, especially the ones for benign or inflammatory conditions, are elective, and so we were held up in not being able to do these cases both in the initial spring as well as again during the summer and winter surges. So the delays caused either by postponed surgery scheduling or patients that delayed seeking care, we saw the results of that, and that many patients suffered consequences of untreated disease, and we saw last year many patients who progressed and required emergency treatment for these cases of delayed care with regard to sinus conditions. You already heard from our laryngologist, Dr. Yip, and the team of speech pathologists that she works with. She mentioned mostly the airway laryngeal disorders because these are ones that are have been seen a lot with COVID. But she also treats many swallowing disorders, voice disorders, care of the professional voice, chronic cough, vocal cord nodules, as well as minimally invasive surgical treatment of early larynx cancer. Some of the challenges that were faced in laryngology care is, as already mentioned, many interventions are possible in the clinic, but unfortunately they're very highly aerosolizing, and so measures to be able to do those safely over the past year. Public performing arts performances are still really not happening, and so a lot less voice patients are seeking care. And then the challenge with some of the conditions that Dr. Yip showed in her presentation, many of them are considered elective until they're not. And so a case of partial airway obstruction, cord paralysis, or things like that can become emergency airways if they're left alone and allowed to progress. And we certainly saw that happening multiple times in the past year. Finally, I want to share with you our excellent otology, neurotology team, including the director, Dr. Nick Deere, Dr. Heather Kaufman, joined with our PA, Chris Adams, and our team of audiologists that work with us in our clinic. They deal with really a range of conditions, working closely with audiologists for conditions related to hearing loss, as well as both benign conditions and tumors that involve the ear and the lateral skull base. Really, as I said at the last line, anything else that involves the ear, our team is happy to see. The challenges that they face, and I didn't face a particular slide with this, is that, again, related to many of these conditions really certainly are elective, and patients may delay seeking care with that. We definitely saw an inverse relationship in terms of our otology clinic volume drop whenever there was a surge, and then came back pretty powerfully in between those surgeries. And certainly we're seeing a very brisk rebound at the moment. So in closing and talking about our ENT, I'm really proud of the way that our ENT team has come together in the past year as we faced many challenges related to the COVID-19 pandemic. I'm really proud that none of our ENT clinical providers got COVID this past year. To our knowledge, there was no workplace transmission that occurred in our clinics or between our ENT patients and any other healthcare workers. And this is really quite significant because Arizona actually twice in early August and again in late December, early January, led the world in coronavirus prevalence. In contrast to some of my ENT colleagues that I talked to in the Northeast, where in some cases they tell me that a third or half of their team got COVID infection, mostly in the spring and the early days of the pandemic. And so it does seem that timing is everything, and we fortunately had the time to prepare for the two major COVID surges that affected our community. So it's interesting, as I mentioned, that initially COVID-19 was not thought to have significant airborne transmission, and so certainly there was naturally heightened concern for activities like what we do in ENT that were highly aerosolizing. Now we know that aerosolization of COVID is actually common, and airborne transmission is the predominant means of spread. And so it means that there's likely airborne transmission risk for many other common activities, not only in medicine, but in everyday living. And these are important to be aware of. And so I think that what we did as an ENT specialty with regard to enhanced PPE, to frequent testing, to looking at the environmental ventilation in our clinics and OR, actually has important lessons for many activities that exist where aerosolization might occur. Bars, restaurants, schools, churches, transportation. And so I think there's important lessons that we can learn from what we as a specialty went through a year ago. My final thoughts as we look at today, that we are hopefully seeing a progress in a successful vaccination campaign. That means that the worst days of the COVID pandemic may be behind us. It may be time that we can ease back on our procedure testing requirements. But I do think that there are some changes that are here to stay. And in terms of our specialty, I think that masking during our in-office procedures, endoscopies and scopes is here to stay. And looking back, it's kind of amazing to me in a sense that that was not what was done. But I think it's going to be part of the universal precautions, similar to how wearing gloves became universal precautions after the HIV/AIDS crisis of the 80s and 90s. In addition, I think that not just in hospitals, but in other areas, that new buildings will start to focus more on having better ventilation. And this will be important not just for the COVID pandemic, but whatever pandemics that might be here to come. So thank you very much. Below is our ENT team at the last time that we had a mass gathering before the pandemic, but I hope that we can gather again very soon. So thank you very much.